Royal Institution, we believe that science shapes our lives, our culture, and the world around us. For more than 200 years, we have been creating opportunities for everyone to discover, discuss, and critically examine science through our innovative public events, world-famous Christmas lectures, YouTube videos, and cutting-edge education programs. Become a member of the Royal Institution today and help us to inspire everyone to think more deeply about science and its place in our lives.
Hi everyone, I'm Martin and I'm the Public Programme Manager at the Royal Institution. Thank you so much for joining us on tonight's stream. I'm really excited to be introducing our speaker later, who's Rohin Francis. But just so you're aware, we've got a few other great talks coming up that I just thought I'd tell you about. So don't forget, on Thursday, we've got a neuropsychologist, Mark Solms, delving into the mystery of consciousness. Then next week, two fantastic events. We've got Anders Sandberg from the Future of Humanity Institute at Oxford, talking about the value of humans in the age of automation. And then we've got Dean Burnett, who's the psychologist, neuroscientist from Cardiff, talking all about psychological and how our brain works and plays tricks on us. So that's going to be absolutely fantastic. So don't forget those. Before we get underway, just to extend a special welcome to members and patrons of the Royal Institution. For those of you that aren't aware, members and patrons can be anyone at all. You don't have to have any qualification, you don't need to be nominated, you don't need to be a scientist, you just need to be a person that likes science, likes the Royal Institution, and likes to get involved and support our work that we do across, the live streams that you're seeing here, but also all our education work and all the other stuff that we do, that you saw in that wonderful video. So thank you so much to our members and patrons. We really, really appreciate your support in these very difficult times. Secondly, if you haven't seen already, there's that chat box that's ticking away on the right-hand side of the screen. I always forget which way I'm mirrored. I think it's that side, but if I'm pointing the wrong way, don't get upset. So please do introduce yourselves. Lots of people are saying where they're watching from. Loads of all over the world. Very international talk. This one we've had Australia, Japan, Pakistan, loads of people. So do say hi in the chat, and of course I'll be monitoring that chat throughout tonight's events. So if you've got any questions for Rohin during his presentation or in the Q&A afterwards, just drop them in the chat, and I'll do my best to put as many to him as I can before our event ends. As you might know, this stream's free, absolutely free for everyone to access, because we know it's really tough out there for a lot of people, and people maybe lost employment or lost work and just feeling the pinch a bit. So we do understand that it is quite tough out there. We do also understand that it's quite tough for the Royal Institution as well. Sadly, we've not been able to sell tickets to our events. We've not been able to hire out our building. We've not been able to do lots of the other things that we do that help bring in lots of money and then support all the educational work that we do with schools, young people, and obviously programs like this one as well. So therefore, there is a suggested installation of £10. So if you do like the event, you want to support us and see more of this and continue us well into the future for another 222 years, we would be more than grateful for any contribution. 10, 100, 1,000, it can be whatever you like. A million, I really can't stop you. Finally, don't forget there's a survey that goes out after the event, so do fill that in if you can. It just helps us know who's watching and the sort of things you like. So that would be brilliant. I think that's pretty much it from me. So I think I'm going to get right ahead and introduce your speaker for this evening. He is Dr. Rohin Francis. He's a cardiologist based in the UK. He trained at London and Cambridge, and he works at the Essex Cardiothoracic Centre, which I only learned to spell about 2 minutes ago. And he's also undertaking a PhD at University College London. Most of you will probably know him as a YouTuber. He makes YouTube videos concentrating on topics don't get covered elsewhere: offbeat science, why modern medicine doesn't work, forgotten chapters in history. But today we're going to be talking about how the sort of blurring boundaries between life and death and how far we can push the human body. So if you can all join me in giving a big welcome to your speaker this evening, Rohin Francis. Thanks very much.
Okay.
Go ahead.
Hi there, everybody. Thanks very much for tuning in today. As you've just heard, I'm a professional hair and beauty vlogger. No, not believable with a face like mine, is it? But I put stuff on YouTube and social media that tends to be about medical science, and I've got this side hustle as a full-time NHS cardiologist at the Essex Cardiothoracic Centre, which is, well, it's in Essex, and I'm going to talk to you today about some extremes of human physiology. It's always been a bit of an interest of mine, and now that's an enormous topic in itself, and really this is going to be a fairly whistle-stop tour. But then again, last week you had Emma Chapman with a talk entitled "The First Billion Years of the Universe." So compared to that, this is actually laughably unambitious. But it's going to be a bit of a whistle-stop tour. So if you do want to hear about any more of these topics in more depth, you're just going to have to launch a relentless campaign at the Royal Institution to invite me back when the Faraday Theatre is open. #Francis for Faraday. And but in the meantime, thank you very much for joining me from wherever you are. I'm sure you've all read stories of tremendous survival and watched top-level athletes and great feats of human strength. And we will be talking about some of those things, but you can read those kinds of stories anywhere, really. And what I want to try and concentrate on today is what's really going on at a biological level. And some of those stories have come into contact with the medical profession, and we've been lucky enough to actually gather data about those cases. But actually, a lot of the stories that doctors tell each other in the doctor's mess, the kind of wild stories of survival, are just normal people that have undergone remarkable circumstances and done remarkable things. And I just want to try and convey quite how amazing the human body can be and how medical technology is supporting that. Now, most doctors who tend to sort of collect stories about patients, write memoirs and things like that, concentrate on the emotion, the human stories. So I don't really know what it says about me that what I tend to do is just catalog all the abnormal test results. Anything that's about 3 standard deviations away from the norm just gets mentally cataloged. And don't ask me to remember your daughter's name, but I'll remember all of your abnormal potassium results. And these are the stories that any doctor sort of looking at them would have thought that there's no chance this person's going to live, and yet they did. And I'm not an evolutionary biologist or anything, but survival of the fittest, the process that's driven evolution, is one of adaptation and survival. The human race wouldn't be where we are today without our ancestors having pushed their boundaries. So this is kind of looking at that on a case-by-case basis. So what do I actually mean by extremes of physiology? Well, to really help convey quite how dramatic some of these things are, I'm going to have to try and fill you in with some of the basics of human biology. Now, I will warn you that I've got 3 slides that are pretty heavy going. I decided to leave them in because I wanted you to see quite how complicated medical science can be, and I wanted you to see that actually, doctors are tremendously intelligent to be able to understand this stuff. So apologies for the next slide, because it is quite complicated, but I'll talk you through it. Yes, this is basically the outline of the talk. There are far less exciting scientists called astrophysicists, and they talk about a habitable zone, but we've got one in biology as well, and that's that little sliver you see in the middle there, that kind of happy place between the bad stuff on either side. And on the y-axis there could be anything, could be temperature, pH, blood pressure, all of these parameters, anything you choose to measure. The human body does a fantastic job of keeping you in that tiny little habitable zone. And the process that's called is homeostasis. And you've doubtless heard of some examples of this, things like sweating or shivering to regulate your temperature, but there are many, many sophisticated mechanisms like how the kidneys or the lungs are responsible for maintaining your acid levels, your pH inside, very, very sensitively. And homeostasis allows us to correct if we wander outside that little habitable zone into one of the areas on either side. It'll try and bring you back to the center, but you go too far and unfortunately there's no coming back. However, some people seem to get way out and come all the way back in. Okay, so the next slide is another complicated one. Again, apologies in advance, but I think it's good to try and demonstrate this pathway to sort of give a bit of structure to this talk, and you'll see the logic behind how I've structured it. You probably remember a lot of those complicated pathways from biology, Krebs cycle, electrolysis and stuff. So it's a bit laughable to try and summarize it on one slide. It's basically summarizing all 6 years of medical school on one slide. And that's it. I know it's another very complicated one, but if you, honestly, joking aside, if you understand this, then you're going to understand most of the concepts in the talk. So the final complicated slide is just to illustrate the kind of people we're going to be concentrating on. That x-axis at the bottom could be any number of parameters again, some measure of function, whether it's heart function, lung function, strength, speed, and we're going to be concentrating on the people at either extremes. Oops, beg your pardon. So you can probably guess that I'm going to start with the most important organ there is, the heart. And you sitting there right now, you've got a cardiac output. That's the amount of blood your heart is pumping in a minute of something like 5 liters on average, which coincidentally is also around the total circulating blood volume in an average person. And that's going around at rest. At exercise, you could probably boost that up if you're in reasonable shape to about 15, maybe even 20 liters if you're pretty fit. However, there are some freaks amongst us who really go way further than that. And they tend to be endurance athletes that combine aerobic endurance with load. And typically rowers and cyclists tend to be the people who have really extreme values for cardiac output, maybe even getting up to as much as 45 liters a minute, way above what the average person could expect. And if you add some performance enhancing drugs into the mix, which obviously is a more recent development in the last few decades, then you get some frankly superhuman values. Arguably this peaked in the 80s and 90s when performance enhancing drug use essentially went unchecked, especially in things like cycling. And there are some athletes from the time, like Miguel Indurain and Marco Pantani on the left there, Sebastian Coe you'll recognize, more contemporary athletes like Bradley Wiggins, Mo Farah. And the numbers on the right of each of those pictures are their heart rates. Now, a normal heart rate, now this is, let's put drugs out of the equation here. I'm not suggesting these people took drugs, although some of them clearly did. But the normal heart rate for a human being is about 60 to 100. Typically about 60 to 80 is where it should sit. And with a bit of aerobic fitness, you can get into the 50s quite commonly. A lot of fit people would be. But once you get into around 30 beats a minute, you're entering into this sixth figure on the list there, who you probably will recognize is an elephant. And an elephant's heart is 60 times heavier than a human heart. And yet these athletes and other hyper fit athletes have got their heart rates down to the same as an elephant. So what's actually going on? Well, through training, they have made their hearts bigger, they've made their hearts more efficient, and also all their tissues are more efficient as well. So they simply don't need to pump their heart as fast, and they can still get a sufficient amount of blood to their body. But of course, just like a Lamborghini engine is happier going around a track, at rest, this kind of freakishly overpowered heart can cause some problems. Athletes who have what we call athlete's heart can suffer from abnormal heart rhythms that wouldn't affect the normal person as much. They can faint, they can have sort of dangerously low blood pressure and heart rate. And as I mentioned earlier, if you add performance enhancing drugs into the mix, things like erythropoietin, which is abused to boost the amount of red cells in the body, then you can get this kind of thick ragu-like blood. And at rest, particularly at sleep, a combination of very slow heart rate and thick blood can actually cause blood clots, which can be fatal. Marco Pantani in the middle on the left there famously had to wake up in the night to pedal on an exercise bike to prevent his heart rate going too slow. And quite a few fit young athletes, or at least who we thought were very fit athletes, have died in their sleep. At the other end of the spectrum are people whose hearts are barely working at all. This is a cardiac MRI scan of 2 different patients, and you can see their hearts are pumping much more weakly than the one we saw a bit earlier, which looks normal. And these are obviously people I meet through work. And particularly when I was working in the heart transplant unit in Papworth Hospital in Cambridge. And there I had 2 experiences that kind of really started me on a lot of this path that will stay with me my whole career. The first was a man who his heart had failed secondary to a massive heart attack. And he had something called a ventricular assist device put in, which is a little pump which sits alongside the heart. It doesn't replace the function of the heart, but it assists it. And he actually had 2 put in because his left and right ventricles weren't working. And that's quite unusual in itself. And he managed to go home, but he came back in not feeling fantastic. And the echo on the ultrasound scan on the right there is not him. That's a different patient. But you can see, if I just use my mouse, I don't know if my mouse projects, you can see the ventricular assist device cannula just sitting in the heart there. But he came back into clinic, and we did a scan and found that his heart had stopped completely. And I'm not using that in a kind of loose sense, like it was an abnormal rhythm. His heart had completely stopped. It was doing nothing. It was completely inactive. He was being kept alive by those 2 pumps, which wasn't what they're designed to do. And, you know, for me, that was more striking and surprising than someone who electively will have their heart taken out for a transplant or have a total artificial heart put in place, because he'd been sitting at home and his heart had stopped and he had no idea until he came in. So this really kind of blew my mind. And it leads to these kind of interesting philosophical discussions about what actually defines death. You know, for the vast majority of human history, it's been the absence of a heartbeat, but that clearly doesn't apply anymore. And the second experience I had in the same job, which was really a remarkable job to do, was watching an operation called a heart-lung transplant, which is, again, a pretty rare operation. That's where the whole, both lungs and heart were transplanted together. And that's not something that happens very often. So I was quite lucky to watch. And we were waiting for the donor heart-lung block to arrive, and the recipient's organs had been removed. And I remember having a few minutes just waiting, standing there thinking, this is incredible what I'm looking at. It's a sort of marvel of combining medical and human technology, that there is a woman lying on the table who is unconscious but alive, and she has no heart and no lungs inside her chest. And I remember seeing this huge open cavity and just kind of, you know, it's an unforgettable sight, something that even most cardiac surgeons won't have seen. And so both of these patients did something that a vanishingly small number of people have done through history. They've been alive without a working heart in their chests. And heart transplantation itself is now over 50 years old, but still something that I find utterly remarkable. There's no substitution for a heart transplant at present, but the mechanical options are getting better and better. And this certainly is a frontier that keeps getting pushed forward. Now, in the short term, we can replace not only the heart's function, but also the lungs. And there's something called extracorporeal membrane oxygenation, or ECMO, which you may well have heard of this year, because with COVID, we've seen unprecedented demand for technology like this. And frankly, we don't have enough ECMO capacity in the UK. But what it is large pipes remove blood from the body, take out the carbon dioxide, put oxygen in, and pump blood back into the body at high pressure, high enough to perfuse the organ. So replacing the function of the heart and lungs at the same time. And at present, this is the limits of what human physiology can survive in the hospital. So back to our curve again, our normal distribution. So again, I was talking about different things going on the x-axis. If you decided to put sort of a measure of aerobic function at the bottom, how would you actually measure this? How do I know that my heart failure patients are on one end of that chart and the elite cyclists are on the other? Well, you can do tests, and one typical test is exercise test, and we measure something called VO2 max. And what that basically is measuring is how much oxygen your tissues can take up. And the higher, the fitter you are, essentially. And that's a combination of not just heart function, but many cardiopulmonary function, as well as your muscles and everything. So just to give you a sense of scale, a sort of typical average person in reasonable shape would have a VO2 max of about 30. My patients, when you're getting to the level where you're considered for a heart transplant, will have a VO2 max of about 10 to 12. The fittest cyclists and athletes who've ever lived, with or without drugs, we'll leave that up to the jury to decide, would have a VO2 max of around 80, possibly even pushing 90. And just to compare us to some of our cousins from the animal kingdom, husky dogs and racehorses are up at 150 or 200. So both the elite athletes and patients with end-stage heart failure are living on the edge in different ways. But let's take a further look at that figure of VO2 max. It's clearly not just about heart rate and heart function, but also what the heart is pumping, i.e. blood, and its iron-bound hemoglobin. So in that respect, even when you're doing a cardio workout, you're actually still pumping iron. Blood, of course, has many purposes, but the main one is delivering oxygen to cells. And as you've heard before, blood's constitution can be changed. Now, not just through performance-enhancing drugs, but the old-fashioned way to do that was to go up a mountain and spend some time there, because the air, the higher you go up, becomes thinner, i.e. there's less oxygen in the air to breathe. There's less air, full stop. And your body's response to a lower level of inspired oxygen is to synthesize more oxygen-carrying red cells. Your blood count goes up, and when you return to sea level, you can transport more oxygen to your muscles. Now, if you're like me, i.e. you're a member of 99.99% of the human population that is not native to the Himalaya, then you can spend a while at Everest Base Camp, like I did. You can reap the sweet increase in your hemoglobin levels, return to sea level with an increased aerobic ability, but after a few weeks, you return to your embarrassingly normal sea level self. The Sherpa are a community who have been native to the Himalayan plateau for at least 10,000 years, possibly a lot longer. And because it is such an extreme environment for humans to live, a selection pressure has actually been exerted on their development such that they are actually now adapted genetically to life at high altitude. Stories of Sherpa survival with incredibly low oxygen levels and just doing things that other climbers couldn't do have been around for generations. But formal study, since we've been able to gather data, has shown that Sherpa found with oxygen levels down in the 40s, saturations in the 40s, and who've gone on to survive have been noted. But studies specifically looking at Sherpa have given us fascinating insights into what's actually going on in their bodies. Things like the fact that they've got bigger relative lung capacity and denser capillaries in their muscles, but crucially, they don't undergo the same counterproductive responses that you or I would suffer at high altitude. Things that our body does that eventually lead to sometimes fatal changes and different forms of altitude sickness. And that's something that their bodies just don't seem to suffer. But intriguingly, their hemoglobin and their mitochondria concentration in their muscles is actually lower than acclimatized lowland climbers, because their adaptation isn't a transient response to low oxygen. It's the very way that their muscles generate energy is different. Sherpa muscles prioritize carbohydrate over fat to a greater extent than non-Sherpa, meaning that they actually require less oxygen to produce energy, and they're less susceptible to oxidative stress. Now, just as a kind of side note, stories like this can sometimes lend credence to ideas that there are clearly observable genetic differences between races, but in fact, examples of noticeable functional mutations like this are extremely rare because most humans just don't live in environments that are so extreme to actually cause these kinds of changes. We believe, in fact, the same genetic mutation that's perhaps responsible for a lot of the Sherpa adaptation also was inherited by ancestors of Han Chinese, but because they didn't live at altitude, it was not favored and it wasn't selected out in the same way. So it's very occasional that we find these pockets where something about the environment has meant a genetic mutation is favored, and we will meet another example of it later. But we shouldn't believe it's only the Sherpa that are capable of utterly outrageous feats at altitude. When medics took blood samples to check oxygen levels near the summit of Everest, the results were lower than anything anyone had expected. Now, a normal oxygen level, this is not oxygen saturations, that you're probably familiar with, obviously goes up to 100. This is what's called a partial pressure of oxygen in the blood, and it's measured in kilopascals. And a normal oxygen level should be about 12 kilopascals at sea level. If you come into hospital and you've got a PO2 oxygen level of about 10, then I'm concerned. I'm probably going to put you on some oxygen. If your oxygen level is less than 8 kilopascals, then I'm very concerned, and you may well end up being put on some kind of ventilator. If it's 6 or lower, you're in serious trouble, and there's a distinct possibility you're not going to survive that. Now, a group of British climbers, 9 men and 1 woman who were roughly between the ages of about 20 or 50 years old, a few years ago, did a fantastic study where they actually took intra-arterial blood samples right near the summit of Everest. And the results they showed, bear in mind, I told you that 8 means severely hypoxic, low levels of oxygen in a hospital patient. They found that the average level was 3 kilopascals. And these weren't sick patients lying in a hospital bed. They were climbing the tallest mountain in the world. So the idea that you can train, you can acclimatize, even coming from a lowland background without any adaptation to altitude, and you can train yourself to survive in the death zone, i.e. over 8,000 meters altitude, where the air pressure is 1/3 what it is at sea level. There's 1/3 the amount of oxygen. Again, I find utterly amazing. I've never seen an oxygen level of 3 in any of my patients in hospital. As you've already heard, the end goal here is oxygen delivery. And we've talked about how increasing how much the heart pumps. We've talked about when the heart doesn't pump enough. So we just talked about increasing the oxygen carrying ability of the blood, but how about the opposite? A normal hemoglobin is defined as around 14 grams per liter. It differs for men and women, but that's probably about average overall. Anemia again is different for men and women, but if you're getting down to about 10 or 11, then that's a significant anemia, a low blood count, and it would certainly need some investigation. At 8, we're in the range where would consider giving a blood transfusion, and that's a serious anemia. Massive bleeds, huge hemorrhage can cause hemoglobin to drop rapidly to about 5. That's very, very severe anemia. But when I worked in a rural hospital in South Africa, I met young patients, adolescents, who through a combination of dietary deficiencies and disease had such profound anemia that they walked in and seemingly fine, not really complaining of much in the way of symptoms, maybe a little bit tired, with a hemoglobin of 2, which again, coming from London and the West, I'd never seen before. But because it had developed slowly, their young bodies had adapted and they were still going. However, the most remarkable case I saw actually was in London. It was when I was working at St. George's in intensive care. A young mum had just given birth, and it was quite a traumatic birth, had a catastrophic loss of blood, which can occasionally occur in obstetric emergencies. And her hemoglobin, which we had to check several times because I just couldn't believe it, was 0.9 grams. And the lowest I can find in the medical literature is 0.6 grams. So this really wasn't far off. And just to put that into context, that's 9% the amount of oxygen carrying hemoglobin that you would normally expect somebody to have. It's probably because she had a pre-existing severe undiagnosed anemia. So again, her body had adapted in some way. But if I can guarantee, if I removed 91% of my hemoglobin right now, I probably wouldn't be able to finish this speech. More importantly, I'd probably die. So the fact that she was anemic for a time beforehand, we think, means that her body had effectively auto-resuscitated. She'd expanded her plasma volume she still had very, very little oxygen carrying cells, but her blood pressure had been maintained. But the fact she could exist with such sort of watery blood still is really amazing. Pregnancy itself is, something we think of as pretty run of the mill, but it is one of the most challenging physical experiences that a human can go through. It is, of course, regarded as routine, but mothers undergo pretty drastic changes in even early pregnancy, but increasingly so as it progresses. Their hearts can change shape. Oxygen consumption goes up. The heart pump becomes more powerful. It actually increases the amount of blood it's pumping with each beat by 50%. Blood pressure can drop. That blood volume, I was just talking about plasma volume expanding, plasma expands, but also hemoglobin increases. And blood pressure during childbirth can actually spike to up to 3 times normal, akin to the kind of values that have been attained with Olympic weightlifters doing a lift. And on the subject of pregnancy, when we talk about pushing human boundaries in pregnancy, a common topic is how early we can support a baby that's born prematurely. And actually the earliest, as far as I can see, that hasn't really been beaten for over 30 years is around 22 weeks. And there seems to be a sort of cutoff around this point that it's very, very challenging, if not impossible, to support a baby younger than that at an earlier gestation, because their lungs are simply not developed enough to support on a ventilator. You might ask that, well, a 22-week-old baby in utero wouldn't be using their lungs anyway, because they're not breathing, they're getting their oxygen from the umbilical cord, kind of like that ECMO system I sent, a pipe going in and a pipe going out, obviously coming from mum in this case. And that indeed is the origins of how ECMO was developed to support these very small babies. Now, this is way outside my area of expertise, but from what I understand, the reason we're just not able to progress past this 22-week limit, is because we simply don't really understand the placenta very well. So that appears to be another limit right at the earliest point in life. Sorry, I did just fell behind with the slides there, but so cardiac arrest is a term that we use to when a patient's heart stops completely. Now, when that occurs outside the hospital, only about 10% of those people are going to survive to a good outcome. I leave hospital in a good shape, possibly even less, depending on the statistics you look at. So already this is something with a 90% mortality. And while all organs suffer from a lack of oxygen, the most sensitive and the one that's most important in terms of recovery is the brain. And without oxygen, the brain suffers irreparable damage within minutes. And it's variable. It depends on the person themselves. In an elderly person who may be in good shape, but as we all get older, changes start occurring in the cerebrovascular system, the little blood vessels in the brain. And there can be some pre-existing damage, which may not even be known. And 3 minutes without a blood supply may lead to irreversible damage, possibly 5. In a young, fit patient, it could be something like 10. But once you get beyond that, it's really bad news. Now, some things can help. You, of course, know the most important one being CPR. And good CPR can drastically improve someone's chances. So please make sure you know how to do it. A high-profile example of just how effective CPR can be was the case of Fabrice Muamba, who is a professional footballer who suffered a cardiac arrest during a league game, and his heart wouldn't beat for 78 minutes. And because of effective CPR, and it's very important to say the fact that he was a supremely fit professional athlete, he made a full recovery from that. And that is way outside what we would normally expect to see. But that's a testament to his fitness and to good CPR. There is something else along with kind of conventional treatments like that that can transform outcomes. And the surprising answer is cold. There have now been many cases recorded in the literature of people surviving an inordinate amount of time without a heartbeat because they were in a very cold environment. often drowning in icy water, which caused their bodies to rapidly cool, which is very important here. There's an expression amongst resuscitationists that nobody is dead until they're warm and dead, meaning that if someone like a drowned patient that is brought in hypothermic through accidental drowning, you don't certify them as dead until you've warmed them up and seen if there's any response. And that's exactly what happened when I treated a young man who was drowned in winter waters, again in London. He had no heartbeat for, we think, at least 10 minutes, possibly quite a bit more, before coming into hospital. And it was 20 more minutes before we saw any cardiac activity whatsoever. His heart was, again, sort of completely at a standstill. And it was several hours before he was rewarmed completely, but 2 weeks later, he left the hospital with no lasting consequences at all, having made a complete recovery. And this was having no heartbeat at all for 30 minutes. Now, to help, we can, these patients look completely lifeless. There's often no normal way that you tell, looking for a pulse and things like that, if these patients are alive. Even scanning their heart won't give you that clue. So we can use certain technologies like measuring the amount of CO2 that comes out of their lungs. If you pump oxygen into someone who's dead, you'll just get oxygen out. But if you get some carbon dioxide out, it suggests that there is still some respiration taking place. But that's nothing compared to the ever-growing list of case reports in the medical literature. The longest cardiac arrest with a full recovery that I could find was 9 hours, 4 hours of CPR. So he must have woken up with the mother of all painful chests after all those chest compressions, and then 5 hours on that ECMO that we talked about. Now, one of the Royal Institution's previous Christmas lecturers and a big hero of mine, Kevin Fong, told the story of Anna Bagenholm, who at the time had the lowest recorded core body temperature in someone who'd gone on to live. She was a junior doctor at the time and fell into cold water and drowned. And her core body temperature when she came into hospital was 13.7 degrees Celsius. And her cardiac arrest lasted over 2 hours. But since then, a 2-year-old boy has actually broken this record, reaching 11.8 degrees Celsius, and again, making a full recovery. But just a couple of months ago, this was published, well, September, which I hadn't seen before. In fact, every time I do a talk mentioning hypothermia, I have to update it because there's always some new case report. But this is actually looking at a case series from the 1960s, which seems to have been forgotten to history. And there were 9 patients in total, but 5 that made a full recovery, the coldest reaching 4.2 degrees Celsius and still making a recovery, which is something I'd never heard before. And it suggests we may not have yet reached the boundary of where survival is in terms of hypothermia. These, as you can see, there were quite a few kids there, but the 4.2 Celsius patient was 39 years old. So it does suggest that maybe the current science fiction of cryonics, which at present, I would class in a kind of very distant future, maybe it's a bit closer than we thought. What about, well, before I move on to heat, I'll just say a final word about hypothermia, because it's not just interesting case reports, it also can teach us how hypothermia can be used in a therapeutic sense. And we now routinely use hypothermia for people who have had cardiac arrests for any reason. And it's gone through different guises and it's constantly being revised, but you can cool somebody's brain after a cardiac arrest to try to get some of those benefits of reducing damage caused by a low oxygen level. And we believe it's because basically you're reducing the metabolic activity in the brain and different organs and reducing how much oxygen they need. Other examples, of course, include putting donor organs on ice, which is something I'm sure you're familiar with, to reduce the amount of damage that occurs after they've been removed from their own blood supply before they're put into their recipient. So what about heat? This is the theme of the talk, isn't it? Going from one extreme to the other. We've talked about cold. Now, heat was something that I hadn't heard that much about, because it's obviously not something that we use in a therapeutic sense the same way hypothermia is. And also I practice in the UK, so overheated patients isn't something I tend to see that often. You all know that a normal body temperature is around 35 to 37 degrees Celsius. And it's important to note that's quite a tight range. Remember that habitable zone diagram, it is quite a thin band. Something like pH, our acid levels, or our internal temperature, anything to do with our internal dynamics is pretty narrow, because things like enzymes need that narrow window to work. It's not like height, where we come in all shapes and sizes. We are all clustered around a fairly narrow range. And heat, temperature is one of those things. Just a few degrees up, 40 degrees Celsius, in conjunction with neurological signs, is what we class as heat stroke. And that can be fatal, particularly in elderly patients. 42 degrees Celsius, which I don't believe I've seen in practice, would be fatal to pretty much most patients. And yet the hottest core temperature that I could find that someone has survived is 44 degrees Celsius. But actually, we can all tolerate short periods of extremely hot environments like saunas, which can exceed 100 degrees Celsius, as long as our thermoregulatory systems like sweating are intact. We talked about homeostasis earlier. This is, of course, an example of that. There are other mechanisms to do that we use for heat regulation, like dilating the blood vessels at the surface of our skin to radiate heat away. But when the ambient atmospheric temperature is hotter than your internal temperature, that obviously doesn't really work. So it is really about sweating. So this is an onsen bath in Japan. And if you submerge yourself in water, obviously sweating doesn't help then. And then the temperatures that are tolerable actually seem quite modest. Onsen baths can reach about 46 or 47 degrees Celsius. And actually, most people can only tolerate that for a couple of minutes, whereas experienced bathers in Japan can maybe spend an hour in one of these very hot baths. So again, you can train yourself to survive and tolerate these extremes. Sweating, to just expand on that, I found studies looking into the rate of sweating, and the highest rate that I could find was a tennis player in a sort of controlled environment, a tennis player who sweated 5.6 liters in an hour of hard cycling. Don't ask me why they got a tennis player to do some cycling, but I guess that's what they did. So this is a very important way of losing heat, and that's why the Japanese baths are so different. And even in water of 30 degrees Celsius, a raise of 2 degrees Celsius in core body temperature can be observed in a fairly short period of time. And 2 degrees is very important, because, and that just reflects, even in quite modest water temperature, how important it is for the body not to be able to lose the ability to lose heat. You may have heard of Mauro Prosperi, who got lost taking part in the famous Marathon des Sables. Now, in my personal opinion, all ultramarathons are bonkers, but this is one of the most bonkers. It's a very famous example of an ultramarathon because it takes place in the Moroccan heat, in sweltering temperatures. And he, due to a sandstorm, got lost and went hundreds of kilometers off route. And the heat conditions at the time were up to 46 degrees Celsius. And that's he had one water bottle when he got lost. And he survived 9 days in the desert. He reports drinking his own urine, and he also says he caught bats and lizards, and took shelter in a muslin with an N, shrine that he found, and resorted to drinking the blood of these small creatures that he found. Now, some have doubted the veracity of these claims, but when you are able to look at some of the doctor's reports when he was taken to hospital after his ordeal, they said they used 16 liters of intravenous fluid to resuscitate him. And remember, I said that circulating blood volume is normally 5 liters, and your total blood volume is about 42 liters on average. He suffered damage to his kidneys, his liver, and his muscles that actually took a total of 2 years to recover. But again, a quite remarkable story of survival. Let's return to our complicated diagram where we've done the heart, we've done a bit of the lungs, we've done oxygen, we've done the blood. So now we've supplied the tissues in the body, and we need to remove the waste gas carbon dioxide, which is the waste gas of respiration. The normal partial pressure of carbon dioxide is about 4.5 to 6 kilopascals. Now, did you know that the thing that makes you want to breathe, the thing that tells your body, hey, you need to breathe, which is probably not something you think about that often, although you're probably thinking about it right now, is actually your level of carbon dioxide, not your level of oxygen. And this, again, is an example of how sensitive that homeostasis is. Your carbon dioxide level, which sits, as I said, about 4.5 to 6 on average, if it starts creeping up, which can happen from something like holding your breath, then you get this almost irresistible urge to breathe. And that's because carbon dioxide is weakly acidic, and hence a rise of carbon dioxide makes your blood slightly acidemic or acidic. And your body can detect this and says, you need to start breathing. And so actually your oxygen level doesn't cause that same sensation for quite a while. And freedivers are people who dive, frankly, ridiculous depths on a single breath with no supplemental oxygen tank like a scuba diver. And the world record for a single breath hold is 24 minutes. Now, that's using supplemental oxygen beforehand, but even without supplemental oxygen, just breathing air, the world record is around 12 minutes. So again, these are real extremes of human physiology. And the reason they hyperventilate beforehand, and the reason any of you can extend your breath hold by hyperventilating first, although I advise you not to do this unsupervised, is because you blow off excess carbon dioxide when you're hyperventilating. So anyone who hyperventilates and pants, often we see patients who've come in with anxiety and they're sort of having a panic attack and they're hyperventilating, their carbon dioxide level will be very, very low. And that sometimes causes you to feel a bit tingly in your extremities and feel a bit faint. And it also allows you to have this very long breath hold because it takes much longer for your carbon dioxide to get to that level where your body's screaming at you to breathe. And if you can start pushing past that sensation of the high carbon dioxide, then you can extend your breath hold, or what's called a static apnea in freediving circles. And in the short term, a high CO2 isn't necessarily that harmful. I see patients routinely coming to the hospital who are unwell and they have a CO2 value of around 10 or 12, and they fully recover. That's something we see pretty frequently. They again may need assistance of a type of ventilator, but it's the CO2 itself is not necessarily harmful. It's a reflection of what's going on in their lungs. But I've never encountered anything like the next case when a 16-year-old boy fell into a truck which was being filled with wheat grain. And unfortunately, his lungs rapidly filled up with grain. He was pulled out about 7 minutes after falling in. He was unconscious. He was unable to breathe. After clearing as much as they could out of his throat and his mouth, he was intubated with a breathing tube, but they just couldn't ventilate him because his lungs were just full, his airways were full of impacted wheat. Many hours would pass before they cleared his lungs. Now, I'm going to show you, I know these numbers won't mean anything to a lot of people, but I want to highlight a few numbers here. Now, these are in units, it's an American journal, so these are in units that no civilized country should understand, archaic measurements. So I had to do some conversion, and I was sure that I had got the conversion wrong because I've just never witnessed numbers like this. The important thing to first point out is his oxygen level is pretty normal. These numbers for the oxygen are within normal limits, and he was like that throughout, which is the first thing to say is pretty remarkable that even with all that grain, he was able to get enough oxygen in. But his carbon dioxide level is recorded here, the peak at 501 millimeters of mercury. And remember I said normal is 4.5 to 6 kilopascals. This is 67 kilopascals. It's just utterly wild. But it, again, is a reflection of the fact that the carbon dioxide itself isn't that harmful. And once they were able to clear everything out, he did much better. The treatment essentially consisted of turning him upside down and just banging on his back until the grain came out. Very high-tech medical solutions we have. And if you look at his pH here, now I'm sure I don't have to tell you, pH is a logarithmic scale. So a normal pH in a human being is 7.35 to 7.45. His pH is 6.59 at its lowest. And if I see a pH in one of my patients, the majority of whom are middle-aged or elderly, of around 7, that's really bad news. If I see a pH of less than 7, I'm afraid the majority of those patients are not going to survive. Again, I've never seen a pH get down to 6.59 and for the patient to survive. And there is another saying in medicine that teenagers are unbreakable. And certainly as an adult doctor, I don't mean I'm an adult. I sometimes wonder about that. I mean, I treat adults. I just, occasionally get involved with the care of adolescents when they're kind of at the cusp. And the numbers that we see that adolescents, teenagers can survive is just bewildering. But as I said, thankfully that particular teenager survived, and I was no doubt making a TikTok the next morning. But the report did say that he was coughing up grains for a week afterwards. Plunging back into the depth, there is, of course, a lot to say about the physiology of diving. And actually, I found diving physiology, the most complicated area to study, much more complicated than altitude or aviation medicine, because the things behave very strangely when you're under tremendous pressure. The world, I was talking about freediving earlier, the world record for freediving depth, again, is one I had to double check to ensure I'd converted it properly, because it sounds completely crazy. Because anyone who's done a bit of basic scuba diving, I've done that level 1 beginner's scuba dive, thinks that 18 meters, that's pretty deep, because that's as far as you're allowed to go to begin with. And the deepest someone has dived is 214 meters without any supplemental air. Now, they did that with the assistance of a sort of sled and a buoyancy aid to come back up. So I guess you could say that's kind of cheating, extremely dangerous as well. But the lowest someone's gone without any assistance, so not jettisoning any weight or anything like that, is 120 meters down. That's 13 atmospheres, 13 times the pressure at sea level. And I'm sure diving can be extremely dangerous. The main risk from diving is posed by dissolved nitrogen in the blood and tissues, forming bubbles as a diver ascends. And we all know this phenomenon because we've all opened a bottle of fizzy drink, and if you open it quickly, you get loads of bubbles. If you open it slowly, the gas comes out in a much more controlled way, and that's why divers have to ascend slowly. Free divers don't get the bends because they're just not down long enough for nitrogen to start dissolving into their tissues. And bubbles in the bloodstream is seriously bad news. But divers with supplemental oxygen or air can stay down a lot longer, and then that's when you start getting nitrogen dissolving into bodily fluids. Freedivers can suffer this if they don't leave enough gap between dives. So traditional communities of pearl divers in Asia and in the Pacific have got words in their culture for something like the bends, phenomenon that occurs when a diver doesn't leave long enough gaps between dives. But when we start using supplemental gas, then we get into this territory where these gases can do strange things. Nitrogen can start saturating your tissues. Jacques Cousteau described nitrogen's effects at depth as the rapture of the deep, somewhat similar to being drunk, but it can lead to narcosis. Oxygen which we need to survive, too much of a good thing at pressure can become toxic and can cause seizures and even be fatal. Now, this can be counteracted by mixing other gases with oxygen, things like helium, meaning that humans can exist for prolonged periods at depths of several hundred meters. Now, because decompressing takes so long from a very deep dive, it's led to something called saturation diving, where divers will spend sometimes weeks at high pressure and then take days, maybe 10, 15 days to decompress gradually to sea level. And this means there's only one chance to get the bend. So it's safer than having repeated decompressions, but there's probably also a monetary argument here, because a lot of the companies that tend to hire saturation divers are obviously doing deep sea work, but oil related, and you have to pay divers as they're decompressing. So you want to maximize the amount of time that they can work and just pay for one decompression period. Now, interestingly, as helium is a much better conductor of heat, the chambers that they live in during this period have to be kept at very much higher temperatures, about 30 degrees Celsius, so they don't get cold. And of course, they will sound fairly squeaky when they talk. The Hydra 8 mission in 1988 pressurized divers to 53 atmospheres over 4 days it took to compress them, and then they performed tasks in the water. Now, this is, you know, without any special suits. This first picture was a picture of a saturation diver, so you know they've got these are not pressurized suits, so the human body is tolerating this pressure, and they were doing work at 534 meters depth. It took them 18 days to decompress afterwards, and they breathed a quite remarkable mixture of gas: 49% hydrogen, 50% helium, and 1% oxygen, but obviously under that kind of pressure. So nitrogen was completely eliminated. Most saturation dives are nowhere near that deep, but at present that represents, again, the extreme. There have been simulated dives, so in pressure chambers not at depth, that go down as far as 700 meters, but this is the deepest saturation dive. I'll wrap up the diving story with the incredible Bajau people. Now, they're a group spread across Malaysia, Indonesia, and the Philippines, whose traditional livelihood of fishing, diving for fish, has been their livelihood for hundreds, if not thousands of years. And it's possible for Bajau to be born, live, and die without ever setting foot on land, with these kinds of what they're called floating villages, although they're often on stilts like this. Now, often, understandably, this is becoming less common in the modern world. But one legacy of their history may well live on. The Bajau have been noted for their diving prowess in all the communities where they're known. People will tell stories about fishermen that can hold their breath for 5 or 10 minutes on a single dive. But is this just a cultural tradition that, you know, these people will learn from childhood to dive, and they're just very good at it? Or is there something more going on? A couple of years ago, they were actually studied to try to understand, you know, what's going on. And interestingly, they found that Bajau had larger spleens than ethnically similar people from the same part of Indonesia where this study was performed. And that's quite an interesting finding. Your spleen is I don't know if you can see me, it's just over here on your left. And the spleen is important in diving because there's something called the dive reflex, which is this fascinating instinct that's common to all air-breathing animals, we think, but particularly pronounced in mammals. So it's often called the mammalian dive response. And it's part of what allows marine mammals like seals and whales to dive for over an hour, maybe even up to 2 hours in some cases, on a single breath. And it's present in humans as well. And it's triggered by immersion in water, particularly the face being immersed in cold, especially water. And when that occurs and when they dive, and this happens to us as well, your heart will slow. In the case of a blue whale, as slow as 2 beats per minute. and blood is diverted away from your extremities to your core, to your important organs, chiefly the heart and the brain. And there's also a hydrostatic pressure when you're diving that pushes on your legs to push blood into the center of your body as well. Interestingly, as a side tangent, that's why ocean rescue winches people up flat. I don't know if you ever noticed that. I kind of wondered why we lift people out of the water flat, when they're sort of bobbing around upright in the water. And there's this phenomenon of people looking okay when they're in the water, and as soon as they were winched out of cold water, they would have a cardiac arrest. And they figured out that what was actually occurring is when you take somebody out of the water, that hydrostatic pressure on their legs is taken away. So blood suddenly rushes to the legs where it wasn't going before. The legs are very cold. So the blood goes there, it gets cooled, and then the cool blood returns to the heart and causes a cardiac arrest. So that's why ocean rescue takes people out of the water flat. Just a bit of a random tangent there. Sorry, what was I talking about? The dive reflex. And one of the things that occurs in the dive reflex is that the spleen contracts. It's like this little blood bag squeezing a bit of extra blood. And we see that occurring as well in hemorrhage. So when somebody has a trauma and they bleed, the spleen will squeeze and give this little boost of blood. It can be sort of 500 mils, so not inconsiderable. And the bajau, having a larger spleen, is somewhat analogous to marine mammals having very large spleens in comparison to their land-based relatives. So, and interesting, this is something that was seen in bajau who aren't sort of habitually diving, people who, some of the women who are not taking part in regular diving, and they still had that finding of the large spleen. So, is it possible that we've seen this a selection pressure exerted over 1,000 years or so? It's quite possible. Every doctor, especially those working in the intensive care, has stories of patients that survived against all odds, and that's kind of what I've been talking about in this speech. But it would be disingenuous for me to say that those aren't hugely outnumbered by stories where patients' bodies were simply pushed too far over the edge. I know we've all gone through a lot over the last year, and probably the only medicine that you've heard about has been COVID related. So I wanted to kind of take this opportunity to get your minds off COVID for an hour or so and sing a little love song to the wonders of modern medicine and the science that has brought us to where we are today. And yet sometimes it still feels like medical science is under threat by people who refuse to believe in the progress we're making. So I hope you can see this is just one small example why medical science and research is worth defending and worth fighting for. I was at work just today and did a case where a patient came in, and without exaggeration, they were at death's door. They were having a very big heart attack, and they were well outside that habitable zone. Their blood pressure had dropped really low from a heart attack, and they were, would have died without some assistance. And with the whole team there, in a process we've done many times over, we stopped the heart attack, opened up her artery, and restored her to that little red sliver in the middle, that habitable zone. And to be honest, there was really nothing notable. It was totally routine. It's something that teams like mine do every day all over the world. And the fact that we can do that, we can move somebody from that those fringes back to the middle and think nothing of it, is really through standing on the shoulders of giants. There are many areas that I didn't have time to talk about. I hope you enjoyed this kind of brief overview. I do talk about stuff like this on the YouTube channel, so please go ahead and subscribe. But importantly, please also subscribe to the Royal Institution's YouTube channel. They're almost at 1 million subscribers, which is very exciting. And I want to give them a big thank you for giving me this opportunity to talk to you today. And I hope you found it, if not useful, then at least interesting. And you can find me at all the usual time-wasting social media platforms with that handle. But thank you very much.
Wow. So with enthusiastic clapping going on in the chat, it's time for me to crack on with the questions. Thank you so much, Rohin. That was absolutely fascinating. And thank you to all of you in the chat. There's been some really lively chat going on. Lots of questions, lots of, well, you might call them med-curious people. Lots of people thinking about doing medicine at university and discussing what courses they might do. So in a little bit at the end, I might ask you a few questions about your own career path and what university you choose if you were doing it all again. But I'll jump straight into the questions. There's been lots of great stuff. Also, thank you to somebody called Chris in the chat who seemed to be a medical professional, a perfusionist, which is a job that I didn't realise had a name, but apparently it does. Rohin, would you like to explain what a perfusionist does?
Yeah, well, a perfusionist has a number of different roles, to be honest, but I guess the main thing is in cardiac theatres. They're the person responsible for the extremely complicated cardiopulmonary bypass machine. So we talked a little bit about ECMO. They also will look after that in a lot of places. And cardiopulmonary bypass is a lot like the ECMO machine. It's a whopping great device which replaces the heart and lung function while somebody is undergoing surgery on those organs. So I couldn't even pretend to follow half the stuff perfusionists talk about. So it's a very, very difficult, complicated process.
Yeah, fantastic. So I'll launch into the questions in roughly the kind of order that you did the talking. So I've got a few questions about elite athletes, and then we'll go on to a few questions about high altitude, and then we've got some other questions from the end as well. So I just had a question before we go into the audience questions, because I it's my stream and I can do this, which is my resting heart rate is weirdly about 45-ish, and I'm I go running every other day. I'd probably say about 10 or 15 kilos overweight. I'm not, I'm not in terrible shape, but I'm not in amazing shape in any way. So how is that possible? Because I'm clearly not Miguel Indurain or Mo Farah.
Well, I don't really want to sort of remotely diagnose anything, but there is obviously a variety in what we define as normal. I think if your heart rhythm is entirely normal, then you're probably fitter than you think. If your heart rate's in the 40s, mine has just crept out of the 40s, sadly, with lockdown. I used to be quite proud of my resting heart rate, and it's creeping up as I think a lot of us have struggled to get our requisite exercise with everything that's been going on. But if you're feeling fine, that's probably nothing to worry about.
To be fair, that was maybe a year or so ago when I used to wear a Fitbit and I was a bit thinner than I am now, and lockdown hadn't taken its toll. Anyway, on to the audience questions. So Garth asked a question about: is there anything to think to the notion that elite athletes suffer from enlarged hearts in their life, and does the heart change sort of shape and size based on kind of different exercises? Say if you do a lot of strength versus a lot of endurance versus, does that affect anything, or is it all kind of the same?
Yeah, that's a great question. That very much so. So there's a whole subspecialty really within cardiology which is dealing with athletes, and in a nutshell, the changes that we see in highly trained athletes is, yes, the heart absolutely does get bigger, and normally when we see cardiac enlargement, that's a bad thing, because that means that our heart is struggling. So the kind of patients that come in to see me who are unwell often have very dilated hearts. This is a different kind of enlargement. This is obviously physiological, and so it means that with each beat the heart can eject more blood. The wall of the heart starts to thicken, just like any muscle. It will, if you work it out, it will start thickening, and that is a very interesting thing. And there's no clear way to differentiate between changes that are problematic and changes that are purely caused by training. And so sometimes, particularly in athletes who are maybe in their 40s and older, we'll see people who are clearly very, very fit, but they'll have hearts which are kind of borderline. We're not really sure if this is purely athletic heart or if there's something going on, like there is some abnormal thickening of the heart muscle. And a lot of the time, unfortunately, the safest thing to do is to ask athletes to detrain, to actually stop training, and then seeing what happens to their heart and seeing if it returns to normal. And in response to the question about different exercises, that's very true. The athletes who combine endurance with load tend to be the real extremes here, who are rowers and cyclists, because they are not only aerobic endurance athletes, but they're also sort of pushing against sort of using their big muscles. And so they will have a combination of that thickening and enlargement of the heart. But yeah, absolutely, you know, there's a lot of research going on in that field. There are a lot of complications that can develop. I sort of touched on them briefly. We know that people who've got athletic hearts are more likely to get different abnormal rhythms, particularly a bit later on. So yeah, it's a fascinating field, actually. Yeah.
And so moving on to the Sherpas, but actually I might link this back as well. So you kind of said that they've evolved over time, like they're now genetically sort of distinct in their sort of amazing cardiac abilities. So, for example, how long would it take athletes, if you had, you know, a family of athletes, how long would it take for that to be passed on, if ever, or are we talking thousands of years? And then I guess the second thing is, Nikki also asked a question saying, do you think it's due to ancestral links with the Denisovians?
Oh, somebody's been doing a bit of reading there. Yeah, we do think that the mutation, which is nicknamed the super athlete gene, may well have been inherited wholesale from the Denisovans. So the Denisovans were a primitive, well, that's the wrong word. They were a human species that we know a remarkable amount compared to how much we've actually found of them. You know, a lot of the information we've got from them is from some finger fragments in the Denisova caves in the kind of Russian-Chinese border, I think. And they, like the Neanderthals, you know, they have passed on some of their DNA to modern humans. We will have interbred with them. And so people in that part of the world, you can trace some DNA back to Denisovans in the same way that a lot of Europeans can trace their some DNA back to Neanderthals. And we think that this gene probably came from them. And so I mentioned that the modern Chinese probably also got this gene as well, and it is seen there, but it doesn't appear to have been selected out. So there's no sort of population-wide benefit there. And I think, I know you're kind of asking a bit tongue-in-cheek about breeding a sort of family of athletes, but remember, this is something that is because they were living in this very extreme environment where there's a very real survival benefit from being able to cope better in that low oxygen setting. So before sort of modern civilization and you know, medical science, that really would have been a significant advantage. So that is something that I don't know if you know. As I said, I'm not an expert in evolution, but I think there's a difference between sort of trying to selectively breed a certain thing. I mean, that's called eugenics, so I don't really want to advocate that. But you know, this is quite an unusual case. I don't, you know, when I talk about this, sometimes you know, the comments I get, I feel like people are maybe getting the wrong end of the stick. It really is quite an unusual case.
Mm. So just going back to what you were when you were talking about the hearts and in terms of heart cells, someone said that, didn't you say in a video previously about why isn't there heart cancer, that we don't grow new heart cells? But then when you were talking about pregnancy, I think you mentioned something around that. Could you just explain that?
Yeah, I mean, it's like the athletes. It's not the heart cells that increase in number. It's that the cells get bigger.
Yeah.
And so all sort of remodeling of the heart is not caused by an increase in heart cells. And it's true, there's a very limited regeneration capacity for heart cells, which is why, you know, someone like me has got a job, because when there's damage to the heart, a lot of the time it's completely irreversible, and that damage doesn't get fixed. So there's a stat that again I've sort of mentioned before, which is that we're born, we think, with about 50% of the heart cells that we die with, and there's only a limited amount added, mostly in the early years of life, and thereafter, that's it. And it in a similar way, neurons as well have a similar kind of thing, which is why we don't see much brain cancer. The brain cancers that we do see are to do with support cells, but actually neuronal cancer, like heart cancer, is pretty rare because the cells are just not dividing very commonly, so you don't get chances for errors to occur, whereas tissue that divides very rapidly, breast, stomach, colon, that's where we see cancers, because there are lots of opportunities for mutations to develop and then become cancer.
That makes sense. So later on in the talk, you were talking about sort of hypothermia and extremes of sort of cold and heat and these kind of things. So Martin asks, are any of these extremes actually used in medical treatments? And Garth said, I think hypothermia can also help with recovery from brain injury. Is that right?
Yeah, absolutely. So, we do, there's still some ongoing research, and having worked across a few different centers, there is very sort of variation in what different places do at the moment. So that just reflects that we're still figuring it out about what to do after brain injury, and cardiac arrest that I mentioned essentially is inevitable. There will be some brain injury in anything, the very shortest cardiac arrest. So it's the same kind of thing. And one option is to just cool the head. So you'll often see in intensive care little cooling hats that go onto patients. Some places will cool the entire body. Some places will use a catheter that sits inside and cools the heart itself. Obviously, that's when the heart is kind of the culprit to begin with. And there are other uses of hypothermia in medicine. It's hypothermia for cardiac surgery was much more in vogue a few years ago. Watching perfusionists will know much better than me that it's kind of gone out of fashion in most places now, because cardiopulmonary bypass has become so much better. So if you wanted to operate on the heart in the past, you'd have to cool it so it effectively stops or beats very, very slowly so you can work on it. And so people were cooled to very, very low temperatures, akin to the cases we saw of people who drowned, and the surgeon would work on the heart very quickly and then rewarm it. But now we don't really need to do that, because you can just reroute blood via the bypass machine. So, but hypothermia was certainly used in cardiac surgery quite commonly, although less so now. So, and as I mentioned, transporting organs is another use of hypothermia.
Someone in the chat also mentioned did they remake it? I was going to say the 1990 film Flatliners, which I think was based on that.
100% medically accurate.
Yeah,
everything in that film is correct.
Oh, well, that's good then. So we'll move on to a few other questions. So one interesting question that came up was, when you were talking about heat and cold, is there actually any evidence for saunas actually having benefits? Can alternating between extreme cold and extreme hot do anything? Is that a good idea, to go in a sauna, jump in a cold bath, get back in the sauna? Is that good?
There's a big question. There is a lot of frankly pseudoscience about saunas out there. I have seen some. I will first say that I haven't looked into this in great depth. I probably should. But yes, there is some evidence that saunas have some beneficial properties, for sure. And the stuff that I recall reading is that they can help with lowering blood pressure. And yeah, I think that was the paper I read. It was looking at sort of blood pressure effects. I'm not aware of anything saying that there's anything particularly harmful with alternating between cold and hot. But I would take with a pinch of salt a lot of the kind of very articles that say that this is incredible and you should build a sauna in your house and everything. I'm not sure that that's really the case. A lot of these trials have no control group. They're just like measuring some people using a sauna and saying, "Oh, do you feel better?" "Yeah, I feel fantastic." "Great." I mean, that doesn't really prove anything, but Yeah, I am aware of some evidence that they are beneficial, and nothing that I've seen that they're too harmful, as long as you're done sensibly.
I mean, I love a sauna, but yeah, I'm not
It
sure.
feels great. I mean, I don't know why people always have to, attempt to prove everything with science. But, we must show that this is just like, if it feels okay, and it's not harmful, why not?
Yeah, I think it's because I think some people like to test themselves, see how long they can stay in there, and go, it must
Yeah,
be doing me
that
good
I
if
think
it's
yeah,
so
I think
much.
that's when you start getting in hot water.
Hey, there we
Hey.
go. Well, it's steam though, isn't it? Or...
Yeah. Sorry. Okay. Ruin.
Anyway, here we go. So our perfusionist Chris asked a really interesting question. He asked, do you think in the near future we'll be able to individualize advanced treatments for patients whose hearts have stopped?
Well, yes, I hope so. I mean, that's kind of the goal with a lot of our treatments. I guess what maybe Chris is getting at there is the difficulty we have at the moment knowing who's going to benefit, and that is one of the biggest problems in this kind of very advanced mechanical support for the circulation, because these are not risk-free procedures. They're very invasive. They can cause all kinds of complications, and we are not very good at selecting who should benefit. And when I looked at this with just small numbers of patients, but it really wasn't. We'd actually did a little study in Cambridge. It wasn't obvious from the demographics of these people going on to something like ECMO, who would actually survive and who would do well. You'd think, okay, maybe the younger patients will do better, but actually, it's more important how long that the downtime, how long they haven't had a heartbeat for, or other factors about them. It's a really complicated picture, and I guess maybe what Chris is asking is how we can stop putting patients through this really quite invasive process when they're not going to benefit from it, and that's a really difficult question at the moment. So yeah, there's a lot of research going on in this field, particularly in Europe as well as the UK. So we'll have to wait and see.
Yeah, because when someone says to me individualized medicine as a non-medical person, my mind immediately goes to things like genetically targeted drugs that are pharmacologically, and it goes to that sort of things. But of course, there's a whole sort of medical treatment side of things that is not drug based, that can also be, like I say, individualized to try and work out what can be of most benefit. So I missed a question earlier, which I'll go back to. It's a question from Lee. When we were talking about altitude and altitude sickness, Lee said, how does Diamox assist in developing high altitude acclimation? I believe Diamox is a kind of altitude sickness drug that you can take. Is that right?
Yeah, it's carbonic anhydrase, and what Diamox does is it essentially encourages you to just take a little extra breathing. So as I was saying, you get this stimulation for breathing based on your pH. So what it does is it just changes your pH ever so slightly to try to stimulate the body to essentially hyperventilate. And because it's something subconscious, you don't realize it, but you just end up taking some extra breaths. So that's really all it's doing. It can't generate any more oxygen or anything like that, but it's just stimulates a little bit of extra hyperventilation, which can mean that you get in a bit of extra oxygen.
Oh, interesting. There's actually an interesting question that's just come up in the chat, which I thought I'd put to you straight away, which is Leona said they've seen a few scientific articles on studies about injecting new heart cells or using stem cells or that kind of thing to improve recovery and repair damage from heart attacks. But how does it work? How do the injected cells interact with the heart cells? And are there any other alternatives that could be used, or do you know anything about that kind of treatment?
Yeah, I think I won't say too much about it, because I know some people who are kind of involved in the field, and it's kind of one of those technologies that always seems to be coming, tomorrow.
Like nuclear power or
Yeah,
nuclear
exactly.
fusion.
It really is a fascinating field, but I remember talking to a professor about maybe working with him many years ago on something like this, and that didn't work out. But I'm not sure that it's really progressed. Again, this is not my field, but it's something that there are incremental gains happening, but I think it's more just a case that our understanding has yet to catch up with what we can do. So there've been some amazing advances in how we can create stem cells, but at the moment I'm not sure we really understand how to get them into the right place in the heart, how to get them to stimulate regeneration of heart cells in the damaged tissue. So I think it's still a way off. I haven't read anything about it for a while, but last time I did, it was really quite modest benefits in experimental models. And there's ongoing research. I know obviously last year has really kind of nixed a lot of medical research that wasn't COVID related, but I know that one of my friends was involved with this, and it's been really hard to recruit patients because the criteria to get into the study are very, very specific. So they're looking for a very specific type of patient who's had a heart attack of a specific type in a specific place and everything. So I think it's very slow progress, but fingers crossed it will reap some benefits.
No, it's often hard to tell when you read things in New Scientist or you see a sort of headline. It's hard to know whether is this going to be in hospitals next year, or is it still some way off from being sort of regular clinical practice. But that question does lead me quite nicely onto a question from Astrid, who says, well, what recent developments in technology that have excited you the most as a cardiologist? So maybe this technology is a long way away, but is there anything that even in the last sort of 5 years has changed the way you operate or the treatments you can use?
Yeah, I'd say probably the biggest development in the last maybe 10 years or so has been the very rapid increase in the amount of structural procedures that we can do without opening up somebody's chest. So everyone's familiar with things like stents that go in via the wrist, tiny little hole, and we can put a stent in an artery. Now that technology has been around angioplasty has been around for over 40 years. But in more recent years, we've actually expanded that concept to things like valve replacements. So now we can do aortic valve replacements, the main valve leaving the heart through a small hole in the top of the leg, whereas previously we would have to open up somebody's chest and do a big open surgical operation. And initially that came in as something that would only be done to people who aren't fit enough for surgery, because it was regarded as clearly inferior. And then it became clear that actually results were very good. And then it was expanded to people who were much younger. And now we're at a stage where, I think it is going to take over the vast majority of valve replacements. We're also seeing treatments for other valves in the heart done in a similar kind of way through what's called a percutaneous, a keyhole kind of approach. So I think that is probably the frontier in kind of clinical interventional cardiology at the moment, and it's helping patients avoid big cardiac operations. There obviously will always be a role for that kind of stuff, particularly things like congenital heart disease, people born with heart defects that can only be treated with operations. Heart transplants, of course, will always be surgical, and any kind of mechanical replacements. But I think we are going to see a reduction in things like valve surgery. So that's been quite an exciting change in cardiology.
Oh, excellent. Yeah, I hope if I ever need anything, you don't have to cut everything open, because the more you open up and do everything, cut me open and expose me to the world, I think there's more chance of things going wrong.
There's an interesting tidbit here that a lot of the progress in some of these technologies, particularly in stenting procedures, comes from Japan, because culturally it's believed that if you open the chest, the soul will escape. So it's very inauspicious to open the chest. So Japanese patients will always opt for a keyhole approach if they can, rather than open chest surgery. So it's meant that actually a lot of the progress in these kind of procedures has come out of Japan. So that's just an interesting cultural tidbit there.
Oh, fascinating. We're almost out of time, but I just want to ask you one more question. I noticed a lot of people in the chat were talking about, where they were going to study, and a few people were chatting about what courses they fancied doing or which university they fancied going. So I don't know if you just wanted to say a little bit about how you got into medicine and any advice on what the best university is and why that's the University of Cambridge.
Oh no, my undergrad St George's
okay.
from London. Medicine is actually a field where it really doesn't matter where you go, actually. And there was some viral tweet the other day by some journalist talking about the prestigious medical schools of London and Cambridge. But actually, so we all kind of made fun of this, because medicine is a degree. It's the same degree everywhere in the UK. And I really wouldn't agonize over the destination. And in fact, I would say that if I were sending my kids to medical school, which I'm definitely not going to do, that's the one rule they have, is that they can't go to medical school. But I would probably send them off to somewhere outside of a big city, somewhere with a nice campus, that they can really enjoy the student life. And I know, having said that out loud, I know that sounds ridiculous at the moment. I feel very sorry for the current students with everything that's going on. But I absolutely loved undergraduate in London, and I'm very proud George's graduate. So joking aside, if you want to go into medicine, it's a very rewarding career, but do your research first and go in with your eyes open. But don't worry about where you study. It's not like, English or some science degrees where there are clearly one sort of top universities that will give you a very prestigious degree. You come out, you come onto the ward, and if you're a junior doctor, I'm just going to treat you like a dog's body wherever you come from. It doesn't matter.
No, I think that's right. And yeah, I think most people, wherever they end up at university, often end up just having a great time, and often maybe it wasn't the place they picked or they thought they were going to go. Certainly my wife ended up in Manchester, where she never thought she was going to go, and had a brilliant time.
Yeah, Manchester is a great place.
So wherever you end up, I'm sure you'll have a fantastic time. So just a few things for me to say before I let everyone go. Don't forget that anyone's welcome to join the Royal Institution as a member or a patron. And don't forget that if you enjoyed tonight's stream, we would really, really appreciate a donation. It could be as little as £10 or as much as £1 million. I don't mind. Don't forget to fill in the survey. Don't forget also, we've got another talk coming up all about consciousness on Thursday with Mark Solm. So do check that one out. Just to reiterate, Rohin, please, if you're all Rohin Midlife Crisis subscribers, please do subscribe to the Royal Institution's YouTube channel. And if you're all Royal Institution YouTube subscribers, please do subscribe to Rohin's channel. Rohin, do you have any other places where people can find you? Are you at Medlife on Twitter? Is that right?
At MedCrisis on Twitter and Instagram. And I've just launched my TikTok career.
Oh, amazing.
Yeah.
You're probably like one of the last doctors to have done that, surely.
Yeah, exactly. I won't be doing any dances. Well, maybe I will. Who knows? But I've made 6 TikToks. I'm a pro by now. Pro.
Oh, fantastic. Well, we'll have to subscribe and see what you get up to. Well, thanks very much, Rohin. That was absolutely fantastic. And thanks to you all.
Martin.
Oh, no problem at all. We literally contacted him through the contact form on his website because we were so keen to get him. So thank you so much for accepting. Thank you to everyone watching. We really appreciate your brilliant questions, and we'll see you all next time. Take care. Goodbye.